Dr. Carajo and Dr. Yassim, I want to extend my sincere appreciations for this YouTube meeting, if you would. With me, I apologize for not being able to be there in person, but my university and my wife felt it safer for me to be at home with the recent events in the Middle East. I hope in the future to meet with you in person and be able to discuss this project that's so dear to me at a later date. By introduction, my name is Ken Moise. I'm professor of OBGYN and professor of pediatric surgery at the McGovern School of Medicine in Houston, Texas, in the United States. I am also a member of the Fetal Center at Children's Memorial Hermann Hospital in Houston, Texas. I've spent the better part of my 30-year career in maternal fetal medicine, researching and developing clinical methods for the detection and treatment of rhesus alloimmunization and its effect on the baby, hemolytic disease of the fetus and newborn. In the U.S., about 85% of individuals are Rh positive and 15% Rh negative, and that is they possess the Rhd antigen on their red blood cells. In the past, the literature would say in Pakistan the rate of Rh negativity was about 7.5%, but more recent data from a pilot project of about 2,000 women, shared with me by Lisa Pell of Toronto Sick Children's in the Dadu district of Pakistan, indicated the incidence of Rh negativity was surprisingly 17%, much higher and more analogous to the U.S. population. As you're aware, the problem with rhesus disease occurs when an Rh negative woman carries an Rh positive fetus who's inherited an Rh positive blood type from its father. This first pregnancy doesn't usually develop any problems, but at the time of delivery, some of this fetal blood escapes into the maternal circulation. It's recognized as being different or foreign to the mother. She develops antibodies to it. And in a subsequent pregnancy, if she carries another Rh positive fetus, these antibodies can cross through the placenta, attach to the fetal red blood cells, and destroy them, causing fetal anemia. Again, the consequences of the maternal antibodies is called hemolytic disease of the fetus and newborn. This can cause severe anemia, cardiac failure, or hydrops fetalis, and even fetal death. In the United States, back in the 1960s, 1 in 167 pregnancies in the U.S. was affected by this terrible disease. But in 1968, two investigators from Columbia University developed an immune globulin called rhesus immune globulin and introduced it to postpartum Rh negative women. And over the course of time, there was a rapid fall in the incidence of rhesus disease to where in 1990, the Centers for Disease Control no longer required reporting this disease on the U.S. birth certificates. The injection, as you may know, is quite effective at 98% effective if given postpartum. It's a simple injection. It does have to be repeated in each pregnancy because it's an immune globulin, not a vaccine. It's very safe. There have been no viral infections reported or major side effects from this particular medication. This is a paper published in 2011 looking at the burden of rhesus disease, particular to Pakistan. They used 2008 UNICEF birth data of 5 million births and used the old literature citing of a 7.5% rate of Rh negativity, which put 290,000 pregnancies at risk. They had access to sales data on 36,000 units of rhesus immune globulin sold in the state or the country of Pakistan, so that 250,000 women were not getting treated, and they calculated that 17,000 fetuses and babies would be affected annually. If we use the more recent data from the Pell project, you'll see the numbers are dramatically increased to where almost 3 times that number of fetuses and newborns potentially are affected on an annual basis. This is hydrops fetalis, which results typically in stillbirth. In the Dadu project of 1,619 women, there were projected to be 17 stillbirths and 27 neonatal deaths. Again, rhesus immune globulin probably doesn't account for all of these stillbirths, but probably is a major contributing factor. And as you're probably well aware, Pakistan has one of the highest, at least based on WHO 2016 statistics, one of the highest rates of stillbirth in the world. Clearly, again, rhesus immune globulin contributes, rhesus disease contributes to this, although it's not accounting for all of these stillbirths. Simple point-of-care testing or bedside testing can be done with a drop of blood. In the DIDU project of 2,000 women, they were able to teach local healthcare workers how to use a drop of blood on this little card to determine the patient's blood type with very good accuracy, and they even developed a phone app to confirm that accuracy in that small study of 2,000 patients. What we are proposing is a 2-arm pilot study in your country. The first would be a prophylaxis arm where we would target Rh negative first-time pregnant women, because we know they haven't developed antibodies yet. We would give them rhesus immune globulin at delivery and would expect it to be about 98% effective in preventing disease. In women who are Rh negative who are in their second or subsequent pregnancy, we would develop a system to screen for antibodies. If none were detected, they would get rhesus immune globulin at delivery. If in fact they had antibodies, we would be interested in working with one of the local hospitals, either AKU or Indus Hospital or both perhaps, to develop a treatment program that might allow us to take care of this devastating disease. One of the mainstays of this particular treatment arm would be the detection of fetal anemia, which can be done non-invasively with specialized ultrasound called MCA Doppler. I was instrumental in helping develop this technique in Houston, Texas some years ago. We now know that if you measure this velocity and compare it to normal values, a value of over 1.5 multiples of the median is consistent with moderate to severe anemia. And we would, as part of this program, teach local physicians in Pakistan and sonographers how to obtain this in a more accurate way. This is just an example of a fetus that was followed throughout gestation with serial values, and when it crossed the action line of 1.5 multiples of the median, we did a cortocentesis and the baby was mildly anemic and was treated successfully with intrauterine transfusions. With experience, this is a series from the center in the Netherlands of over 900 procedures. The success rate for these procedures was 97%, with a 1.2% per procedure complication rate and a 0.6% per procedure loss rate. So once experience is obtained with the right equipment, this can be a very successful treatment for this disease. From the same center in the Netherlands, this is evidence of the learning curve. It takes about 50 cases for a physician to learn how to do this. Depends a little bit on their previous ultrasound skills, and about 10 per year to maintain competency. But again, my goal would be to spend some time with Pakistani physicians and teach them how to do this procedure in an effective manner. The equipment needed for this is not that expensive. We use GEE-10 machines, very good resolution. Those machines run about $98,000 a piece in Pakistan. A Coulter counter is a portable measurement device to measure the blood count at the bedside in the hospital to get immediate hematocrit. And then a fetal cart with needles and supplies might be $5,000. So putting together the treatment expenses would not be that expensive. We've contacted at least one particular group to see if Dr. Khan's foundation might support a pilot project along this line. We are also interested in talking to the Gates Foundation, maybe the National Institutes of Health. But before I leave, I have a few questions that perhaps Dr. Ajax could take down, some answers that you have, and some of those questions for you in your society would be, what do you think the general knowledge of the obstetrical community is regarding the prevention and treatment of Rh disease? Is there a national guideline that the obstetrical community follows in your country? As a standard of care, do most pregnant women get a blood type at their first prenatal visit? What percent currently do you think in your country, maybe private and indigent patients, get rhesus immune globulin at 28 weeks gestation and at delivery, or both? And at delivery, is cord blood typically obtained as a standard in your country for getting a blood type on the baby? Again, this is we're just beginning to gather some data to see how we might be able to put together a pilot project. I appreciate your time. Again, I apologize for not being here in person, but I hope this YouTube video does give you an idea of our zeal and interest in this program. And thank you very much.